Okay, so today we're diving into something uh, pretty crucial for us as ophthalmologists,
Absolutely.
metastatic and invasive tumors affecting the orbit.
Yeah.
It's about recognizing those subtle, sometimes really subtle clues that point to something a bit more um, complex going on beyond the eye itself.
Right. And as ophthalmologists, we are often the first ones to pick up on these things.
Exactly.
Our understanding of the eye and the orbit and the surrounding structures puts us in a really good spot to see these early signs of either spread from, a distant cancer or invasion from something close by.
Yeah, absolutely. And that's what this deep dive is all about, right? Equipping everyone with that kind of practical framework for when they see these complex cases.
Exactly.
Okay, so let's start with adult metastatic tumors.
Okay.
Our sources say that orbital metastases are less common than, say, choroidal metastases,
Right.
but they're significant because they can actually be the first sign of a systemic malignancy.
Yeah.
And here's the thing, up to 70% of them come from breast cancer,
Oh, wow.
which is huge, right?
Yeah, that's a big number. It's a really important association to keep in mind. I mean,
Absolutely.
whenever an adult patient comes in with any new unexplained orbital signs, you've got to think about their history.
Yeah,
Have they had breast cancer?
absolutely.
But of course, we can't forget about the other primary sites.
Right.
Lung, prostate, skin, melanoma, GI, tract,
Yeah,
kidney.
yeah. And what's interesting is how the presentation can be so varied,
Absolutely.
right? Because these primary tumors are so different.
Yeah, it really reflects the diversity of those primary sites.
So our sources point out that dystopia
Yeah.
and proptosis, those are the most common features. Figure 4.43a actually shows a great example of proptosis.
Right.
But it's not just about the globe's position, is it? We need to look closely at the orbital tissues themselves.
Absolutely.
What are some of the signs of tumor infiltration that should really make us think twice?
Well, you want to look for chrontosis.
Yeah.
That's the drooping eyelid, of course.
Right.
And diplopia, double vision. And then there's this feeling you get when you palpate the periorbital skin.
Yeah.
It's brawny, it's indurated,
Yeah.
it feels almost woody,
Right.
and it's thickened. It's unlike the normal soft tissues.
Yeah.
And when you try to, push the eye back into the socket,
Yeah.
you'll feel a firm resistance.
Right. Right.
Now, here's an interesting one, Anselmos.
Yeah.
The sinking of the eye can actually happen too.
Oh, well.
Particularly with serous tumors.
Okay.
So, that dense fibrous tissue can actually contract and pull the eye back.
I see.
And then we shouldn't forget about chronic inflammation.
Yeah.
Sometimes that's a sign even without a clear mass at first.
That's so important to remember.
It is.
Sometimes it's not the obvious space-occupying lesion.
Right.
It's this more subtle inflammatory picture that should trigger our suspicion.
Exactly.
Now, for those lesions that are deeper back towards the orbital apex,
Yeah,
we might see a different presentation altogether.
that's right.
Primarily cranial nerve dysfunction,
Yeah.
affecting vision, eye movements, facial sensation.
Right. Maybe with just a tiny bit of proptosis.
Yeah, which can make it really tricky to diagnose,
Absolutely.
because that's where investigations come in.
Imaging is critical here,
Ah.
especially CT and MRI.
Yeah.
Figure 4.43b shows a good example of a non-encapsulated retrobulbar mass on a CT scan,
Right.
which is pretty common.
Yeah.
And MRI often shows the same thing, a mass without clear borders.
Okay.
But remember, imaging gives us the structure, but we need histology for the definitive diagnosis.
Exactly. And the source really emphasizes that.
Yeah.
The importance of a biopsy for histological confirmation.
Yeah.
They suggest starting with a fine needle aspiration biopsy,
Right.
less invasive.
Right. But we need to be prepared to do an open biopsy if we don't get enough material.
Yeah. And here's another key point. If a patient comes in with these orbital signs, but no history of cancer,
Yeah.
we absolutely have to look for a primary tumor.
Absolutely.
That might mean working with internal medicine or oncology.
For sure, a multidisciplinary approach is key,
Right.
especially since the prognosis for adult metastatic orbital tumors,
Yeah.
it tends to be poor.
Yeah.
The average survival is only about 4 months.
Wow.
So our treatment goals usually shift to palliation,
Right.
relieving pain, preserving vision.
Yeah.
Radiotherapy is often the main treatment
Okay.
to target that orbital mass.
Right.
And systemic therapies for the primary cancer,
Uh-huh.
those can help control the spread too.
Yeah.
We might consider surgical excision in some cases,
Okay.
but orbital exenteration,
Yeah.
removing the eye and surrounding tissues,
Yeah.
that's usually a last resort when other treatments fail to control the symptoms
Right.
and the patient is really suffering.
Okay, so let's move on to childhood metastatic tumors.
Okay.
Neuroblastoma is one of the most common childhood malignancies,
It is.
and it originates from neural crest tissue,
Yeah.
usually in the abdomen.
Right.
Figure 4.44a shows that really well. And the scary thing about neuroblastoma is that in almost half of the cases,
Yeah.
it's already spread by the time it's diagnosed.
Right.
And the prognosis isn't good in those cases.
Unfortunately not.
When it spreads to the orbit,
Yeah.
it's often bilateral.
Right.
So you see rapid onset proptosis in both eyes,
Yeah.
a palpable mass, usually superiorly,
Yeah.
and then that distinctive lid ecchymosis.
The raccoon eyes.
Yeah, exactly.
Yeah.
An MRI can really clearly show the orbital tumor, like in figure 4.44b.
It does.
So that bilateral presentation with the rapid onset and the ecchymosis,
Yeah.
that should really be a red flag for neuroblastoma in a child.
Absolutely.
Okay, now another entity is myeloid sarcoma.
Okay.
It's a solid tumor
Yeah.
made up of malignant myeloid cells.
Right.
You might hear it called chloroma
Yeah.
because it can sometimes have a green color.
That's right.
And what's interesting is its relationship with leukemia.
Yeah.
So it can happen in a patient who already has myeloid leukemia,
Right.
but it can also be the first sign, even before the leukemia is diagnosed.
That's right. It can precede the systemic disease.
Wow.
Yeah. So in the orbit, we typically see it around age 7.
Okay.
Rapid onset proptosis,
Yeah.
sometimes bilateral,
Mm-hmm.
maybe some ecchymosis and lydedema
Okay, so similar to neuroblastoma in some ways.
in some ways. Yeah.
But the real challenge here is recognizing that these orbital findings
Right.
could be the first clue to a blood cancer.
Exactly.
That's a huge responsibility for us as ophthalmologists.
It is.
Now, lastly, in childhood metastatic tumors, we have Langerhans cell histiocytosis.
Okay.
It's a rarer group of disorders,
Right.
characterized by this abnormal proliferation of histiocytes.
Yeah. And the presentation can really vary,
Right, it can range from a localized form
Yeah.
with bone destruction.
which is often called eosinophilic granuloma,
All right.
to multifocal bone involvement
Uh-huh.
or even a severe systemic disease.
Wow.
Yeah.
And soft tissue involvement is less common, but it can happen.
They can't.
So in the orbit, we typically see osteolytic lesions.
Right. Areas where the bone has been destroyed
Right.
and soft tissue involvement, usually in the supratemporal quadrant.
Okay.
Now, the prognosis really depends on how extensive the disease is.
Yeah.
Solitary lesions tend to do much better,
Okay.
and they often respond well to local treatments like curettage, steroid injections, radiotherapy.
Right.
But systemic disease is a different story,
Yeah, much more guarded prognosis.
unfortunately.
So we've seen this wide range of presentations in childhood metastatic orbital disease,
Absolutely.
which just emphasizes how important it is to get a thorough history,
Yes.
do a really careful exam,
Yeah,
and consider all these possibilities
absolutely.
when we're faced with a pediatric orbital lesion.
Right.
Okay, let's shift gears and talk about orbital invasion from adjacent structures.
Okay.
The source says that while malignant sinus tumors invading the orbit are relatively rare,
Yeah.
they have a worse prognosis if they're not caught early. Which means we really need to be on the lookout for both ENT and ophthalmic signs and symptoms.
Absolutely. A combined approach is essential.
And by far the most common sinus tumor to invade the orbit is maxillary carcinoma.
That's right.
Figure 4.45 shows a good example.
Yeah.
You can see the facial swelling and the upward dystopia.
Yeah. It's pretty classic.
So from an ENT perspective,
Yeah.
we need to be aware of things like persistent facial pain and swelling,
Right.
unexplained nosebleeds.
Epistaxis.
Yeah.
Chronic nasal discharge.
Okay, and from an ophthalmic perspective.
We might see that upward dystopia.
Yeah,
Diplopia because the extraocular muscles can be affected.
right.
And epiphora excessive tearing, often due to nasolacrimal duct obstruction.
Okay.
Now, ethmoidal carcinoma,
Yeah,
that might present with a more lateral displacement of the eye.
I see.
And then there's nasopharyngeal carcinoma.
Huh.
It can spread to the orbit through the inferior orbital fissure,
Okay.
but proptosis is a late finding there. And it's often accompanied by other cranial nerve deficits.
So the bottom line is we always need to consider a possible sinus origin,
Absolutely.
especially when we see those related ENT symptoms.
Right.
It really highlights the importance of good communication
Yeah,
between ophthalmology and ENT.
absolutely.
Okay, now the source also talks about bony invasion of the orbit.
Right.
And one of the classic examples is an intracranial meningioma
Yeah.
growing from the sphenoid ridge.
Yeah, those can directly push into the orbit
Right.
and cause proptosis.
Exactly, as you can see in figure 19.58.
Yeah. A really clear illustration.
Yeah,
Now, we also need to remember that meningiomas can start in other places too,
right,
like the tuberculum cellae or the olfactory groove,
right,
and they can still invade the orbit,
right.
often through the superior orbital fissure or the optic canal,
Yeah,
which can lead to early vision problems and eye movement issues,
absolutely.
in addition to proptosis.
Yeah.
Okay, now another important entity involving bony invasion is fibrous dysplasia.
It's a disorder where normal bone is replaced by fibrous tissue,
Yeah.
which weakens the bone and creates a mass effect.
Right.
It usually presents in childhood or early adulthood.
Yeah.
And in the orbit,
Yeah.
it can cause facial asymmetry, proptosis, and dystopia.
Right.
Figure 4.46 shows that.
Yeah.
And it can even lead to vision loss.
Yeah, because of optic nerve compression.
The source differentiates between the monostotic form,
Yeah.
which affects just one bone,
Right, that's the more common type.
and the polyostotic form,
Right.
which could be associated with endocrine disorders
Yeah.
and McCune-Albright syndrome in about 10% of cases.
Right.
So recognizing those characteristic imaging findings.
It's like the ground glass appearance on CT.
Yeah, that's really important for diagnosis
It is.
and for differentiating it from other bony lesions.
Absolutely.
And finally, we have to consider orbital invasion from tumors that start within the eye itself.
Right, from the ocular adnexa.
Yeah, so the source gives us a few key examples.
Like eyelid malignancies.
Like basal cell carcinoma,
Yeah.
squamous cell carcinoma,
Mm-hmm.
sebaceous gland carcinoma.
Right, all of which can grow into the orbit if they're not treated or if they're aggressive.
Right.
And then there are conjunctival tumors, like melanoma, figure 4.47a shows one.
Yeah,
Those can also invade the orbit, especially if they're large or aggressive.
right.
And then, of course, there are intraocular tumors like choroidal melanoma and retinoblastoma. Figure 4.47b shows a retinoblastoma.
Yeah,
Those can extend beyond the globe and into the orbital tissues.
absolutely.
So for us, it all comes down to a careful exam of the eyelids, conjunctiva, and the inside of the eye
That's right. We need to be thorough.
to catch those primary lesions
Yeah.
that could potentially invade the orbit.
Exactly.
So just to wrap up this deep dive, we've seen that the orbit can be a target for both metastatic disease,
Right.
spreading from distant cancers,
Yeah.
and direct invasion
Right.
from the sinuses, the cranium,
Uh-huh.
and even primary eye tumors.
So for us as ophthalmologists,
Yeah,
it's all about having a high index of suspicion.
you got it.
Whenever we see a patient with orbital signs and symptoms,
Right.
we need to recognize that the presentations can be so varied and sometimes really subtle.
Absolutely.
And we have to understand the role of imaging and biopsy in getting a diagnosis.
Yeah.
And we have to keep in mind that the prognosis for metastatic orbital disease is often not good.
It's important to be realistic about that.
And of course, we need to work closely with other specialists,
Yeah.
oncologists, radiologists, pathologists, our ENT colleagues,
Absolutely. It's a team effort.
to provide the best care for our patients.
That's right.
So this brings us to a question for you to think about.
Okay.
Given all the challenges
Yeah.
and the often poor prognosis of metastatic orbital disease,
Right.
what emerging diagnostic tools or new treatment strategies
Yeah.
do you think hold the most promise for earlier detection,
Right.
better treatment,
Uh-huh.
and ultimately better outcomes for these patients?
Yeah. It's a crucial question.
It is.
The field of ophthalmic oncology is constantly evolving.
It is.
So we need to stay informed
Absolutely.
and keep pushing for better care.
Thank you so much for joining us for this deep dive.
It was my pleasure.
Until next time.
See you then.